Good afternoon, everyone. Thank you for joining. This is our first in a series of 5 health equity specific webinars. And Lindsay will be presenting the overview here shortly, but I wanted to kind of tie this webinar into what we talked about on February 28th. If you recall that session, it is on our YouTube channel. We were talking about the new measures coming into MBQuip. And with that said, we have health equity is one of those measures. And so we have an advantage. PPS facilities, are reporting that right now. We have the advantage to kind of watch for a year to see, learn best practices, learn the ins and outs and whatnot. I do want to share this figure here. If you guys recall, last fall, we had the first ever quality framework survey. It was a Qualtrics survey that was sent out last November. We had to have all of our responses in by the end of December. And this will become an annual survey. And this was kind of our benchmarking or our very first one. And so we had 38 of 39 critical access hospitals in Oklahoma complete that survey, which is great. And this is just a summary. If you guys recall, I did send this report out with our last MBQuip reports a few weeks ago. But we're the lighter blue, the darker blue is the national average. So you can see most of the areas, we are just right there with the national average. Now, when we look at health equity right here, this is an area not only do we in Oklahoma need to work on, but we're right here with our peers nationally. And so I know Lindsay can attest to that. She works in many other states as well, but you will be seeing more materials along this topic as well as the other measures that are coming into MBQuip. We want folks to be as prepared as possible as we get closer to those reporting dates. And so, Lindsay, I'm going to stop sharing my screen to let you share yours.
Excellent. So really great tee up to our conversation today. So as I'm pulling this up,
And as Lindsay goes through this, if you have any questions, let me know. I'm happy, I'm monitoring the chat. So please feel free to, if you have any questions, comments, please feel free to include those in the chat.
Excellent. Well, thanks, Laura. So just a little introduction. Lindsay Corcoran, Senior Consultant at Stroudwater Associates. I am really excited to share this 5-part webinar series with you all. Really today is kind of the kickoff, the overview. What are we talking about? What is the plan for the next subsequent webinars that we're going to have? As a reminder, I believe Laura has sent out registration links to all of the webinars. So please sign up or share the registration links. The more the merrier to be able to attend these webinars. Again, as I mentioned, we're going to do just some level setting and really just kind of talk a little bit about what health equity and social determinants of health are. So really, health equity really refers to individuals achieving their highest level of health through the elimination of disparities in health and healthcare. This, again, is a definition from the Kaiser Family Foundation. But you can really understand that there are some differences in terms of definition. The CDC, for example, defines the achievement of health equity as when every person has the opportunity to attain his or her full health potential, and no one is at a disadvantage from achieving this potential, regardless of kind of social position or socially determined circumstances. So really, achieving the highest level of health. And if we can do that by, eliminating the barriers that are in place to achieving that high level of health. But what is health inequity? Health inequity are really these unjust differences in health status, things like discrimination, exclusion of certain groups of people, lack of power, or financial mobility. And one's ability to obtain healthcare services or have access to healthcare services and meet some of their basic needs like housing, food, safe environments are really affected and can be affected by one's income level, their educational attainment, which can be directly related to income level, race and ethnicity, and health literacy. And we know that, and studies have shown that there are health disparities, specifically in rural, compared to urban. And even just being in a rural area, it it's also is a health disparity. Um, we know that in rural, we have an older population, a sicker population, a lower income population. And at the same time, rural doesn't has the fewest options in terms of healthcare services. And you can see that studies have shown even the five leading causes of death, which include heart disease, cancer, unintentional injury, chronic lower respiratory disease, and stroke, that the death rate is higher among rural residents compared to urban counterparts. And then if you even just kind of break it down in rural areas, research have also shown that there's gaps between kind of the rural and urban populations. And there is also health disparities existing between rural and non-rural communities, in different subgroups within rural communities. So, within rural, there's also, a lot of different healthcare disparities and disparities that are existing. And this chart here just can show, the different types of access to care and the demographics, where you're seeing the rural population kind of outweigh the urban population in terms of just the demographic differences between them and some of these disparities here. And with everything, there are barriers, and barriers that exist specifically in rural as it relates to advancing health equity. And sometimes trying to understand and make sense of why the death rate is higher among those five leading causes of death. Why is that higher in rural? And some of these barriers that exist, such as, we have a lower patient volume, which creates, sustainment of healthcare services, a challenge, along with, the workforce, the healthcare workforce specifically in terms of shortages of providers and work, nursing and other kind of tech positions that help support healthcare systems are lacking in rural. We have systematic and institutionalized racism that exists that can really kind of be embedded in communities that can create these barriers to improve and advance health equity in rural. We have different non-health care factors such as food deserts. We have, limited housing and increased poverty and xenophobia and that structural racism I just mentioned, classism, and the lack of transportation, those non-health related factors that create these walls, it potentially in some of these rural settings to advancing health equity. One, and we're gonna continuously talk about this because there's such an importance within, as it relates to data, to advance health equity. Rural, given smaller numbers, we have smaller data sets. We have a infrastructure that is really hinders and can impact the ability to obtain data. And so it puts us at a disadvantage of understanding, collecting the data and analyzing the data to support health equity initiatives, or look for resources to advance health equity initiatives. And so data is really important, but we do have a lot of barriers that exist as it relates to data and the data infrastructure. And we'll talk more about that in one of our other webinars as well. Of course, healthcare providers, and especially healthcare providers that share a similar background to community members. And I think that's something important to kind of point out, that there is that lack of that identification of medical providers back to the community. And sometimes that can be that barrier, that wall that exists. And then again, as I mentioned, some of those lacks of resources and infrastructure to understand the health inequities, whether that is an actual person resource or more of a structural kind of the broadband internet access that can create that wall as well. So lots of barriers. It seems like you're climbing Mount Everest to get to the top to at least try to kind of comb through and advance health equity. It's not easy. It's not an easy task. It's not an easy kind of idea to start. And we're going to kind of think about, how do we start small? How do we think about health equity in kind of these bite-sized pieces to have some of those successes, to overcome some of these barriers here. One other area that's going to come up in a lot of this discussion around health equity is around social determinants of health. And really addressing social determinants of health is really the primary approach to achieving health equity. So very important tie-in here. And you can see, really from this chart, it's, lots of health social determinants of health, multiple factors, the healthcare system, the community, different healthy behaviors, health outcomes, food, education, so forth. According to Healthy People 2030, social determinants of health are the conditions in the environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. One kind of phrase you also might hear is health-related social needs. And there are some differences between social determinants of health and health-related social needs. So I just kind of want to point that out, because you'll hear both. And specific to the MB-QUIP measure that we're going to talk about in just a minute, they're using the phrase health-related social needs. Or social drivers of health is another phrase as well. So health-related social needs are really kind of the cause of poor health outcomes for individual patients. So think about that a little bit, as opposed to social determinants of health, which is more of a term that describes populations. And so when we think about our individual patients and their health-related social needs, it's where we can really find these ways to support health equity and improvement in health outcomes for patients. And so a few examples to kind of conceptualize health-related social needs, is through care planning, and how we, have a patient that's been admitted, and we're going to discharge them and develop this care plan. We have maybe a patient with developed a care plan for the control of their diabetes. But if we don't know if they have food insecurity, then we don't know if our plan for controlling their diabetes is going to be successful, and something that, again, going back to being very specific to that individual patient. So, having a way that we can screen and identify, does this care plan make sense for this patient to control their diabetes? Maybe we need to reevaluate if there is some identification of food insecurity. Similar outpatient radiation therapy may be a challenge for somebody that maybe lacks reliable transportation to treatment. We will not have maybe a successful outcome if this patient cannot get to their therapy appointment and their treatment. So just a little bit of a difference in terms of some of the wording that you may come across. And certainly one of the things that I love this chart. This chart, I think, has been around since the dawn of time, 2016. So you may have seen this chart before. But I really think that this really supports kind of social determinants of health. And really, social determinants of health are influenced by the policies and programs that are developed and associated with better health outcomes. So really, policies and programs that may be developed at the state level, at a community level, the federal level, are really drivers to improving health outcomes, and can be. And you'll also notice that clinical care, which only comprises about 20% of what shapes health outcomes. And you see all these other kind of factors here, social and economic factors. This other 80% is really tied to behaviors and environments, the social and the economic and the physical factors that describe where and how people live their lives. And so when you're thinking about looking to achieve kind of that optimal health outcome, and what is it that we've designed from policies and programs that can impact those health factors here, and only 20%, mind you, being clinical care, that can improve or impact our health outcomes. And so, this is a kind of what you can go on to this county health rankings and look at where your county ranks in terms of each one of these health factors, health outcomes, and policies and programs. It's really interesting information. One thing that I want to point out is, as it relates to health equity, CMS certainly is where a lot of those policies and programs stem from, right? As it relates to health and health outcomes, and some of the factors that support those other factors that we talked about, the clinical care, some of the back here on this slide here, the social and the economic factors and so forth. And I have to just say that, CMS has laid out 5 priorities as it relates to health equity. And they're starting to integrate and have been integrating these priorities into a lot of their programs and their policies. And over the next 10 years, they really hope to kind of operationalize each one of these priorities into all of their kind of programs and their policies. And so they're continuing to work through this, and you can see through the different priorities, expanding collection, reporting, and analysis of data. Priority 2 being assess causes of disparity within their own programs, and address inequalities and policies and operations to close gaps, build capacity of healthcare organizations and workforce, advance language access, health literacy, provision of culturally tailored services, and increase all forms of accessibility to healthcare services and coverage. So you'll see through a lot of the changes that happen on the federal level, we'll take into consideration many of these priorities here. So this brings us really to talk a little bit more specifically about the new health equity related measures. So as Laura mentioned, the PPS hospitals have already kind of adopted this measure. It was came out last year, or actually 2 years ago, I think at this point. And it was a health equity focus measure included in the inpatient quality reporting program. And it was really to assess the hospital's commitment to establishing a culture of equity. And it outlines these 5 kind of core areas. Then this past year, the Critical Access Hospital's MBQIP quality reporting program has now adopted the hospital commitment to health equity measure as well. And following the same requirements that the PPS hospitals are set out to achieve, they are also the critical access hospitals, you all are also going to be required to do that as well. There are 2 other measures, a second and a third measure that is specific to those social determinants of health or social drivers of health. And one is around screening, and the other one is the identification of folks that may have some type of health related social needs, such as food insecurity, housing instability, transportation, utility difficulties, and interpersonal safety. And we'll talk more specifically about that in just a second. The specifics to the hospital commitment to health equity. Again, a new health equity measure, and first released, and the first eligible reported timeline is this spring. And really what we're going to be focusing on for the next kind of year, in terms of your MB Quip programs, is to really prepare you all to report and to attest to the 5 domains that make up the hospital's commitment to health equity measure. And so a lot of kind of building infrastructure, building strategy with the goal, for you all in 2025 to start tracking to submit in 2026. And so that's kind of the reporting timeline you'll see. And again, these are attestations. So this, in each one of these domains that we're going to talk about, each one of the domains has different elements within each one of those domains or sub questions. And you have to attest and answer yes to all of the sub questions to receive credit for that key domain. Very much like the your oh gosh, I just blanked on the program.
Annual facility survey,
The what?
annual facility survey for antibiotics.
Yes, for NHSN. Your antibiotic stewardship. Woo! I just switched gears for a second. But yes, just like your annual survey for the antibiotic stewardship, where you have to kind of attest and meet some of those elements underneath these core domains. So with that, I'm just going to walk through each one of the domains, and this might be new, this might not be new to you all, but again, you'll receive these slides after today's webinar as well. So domain number 1, really it's titled Equity is a Strategic Priority for Your Organization. And a hospital must kind of attest to the following elements: that your hospital's strategic plan identifies priority population who currently experience health disparities. So what's a priority population? And it's something that's very kind of specific to your community, to your organization, but it may be, this priority population may be people that belong to a minority racial or ethnic group, people living with disabilities, people member of a religious minority living in a rural area, some population being below or near the poverty level. Maybe it's a population impacted by some type of the social drivers of health, food insecurity, low literacy rate, access to transportation. So any type of kind of priority population that you all have identified, that you have kind of outlined within your strategic plan. Your strategic plan also identifies health equity goals and discrete action steps to achieving those goals. So is it, have you identified maybe specific resources that would be needed? Maybe you have to dedicate staff or have to go out for additional funding or obtain trainings. What are some of those action steps that you have identified to go through to meet your health equity goal, and have that identified as well? Our hospital strategic plan outlines specific resources that we have dedicated to achieving our health equity goals, and our hospital strategic plan describes our approach for engaging key stakeholders such as community-based organizations. Those key stakeholders could be, such as community-based organizations or organizations that you collaborate with. Maybe it's a patient family advisory group. Maybe it's coalitions or whatnot. But again, what is our approach to engaging for those key stakeholders? Domain number 2 is around data collection. So our hospital can attest to the following activities around collecting demographic information, including self-reported race and ethnicity and social determinants of health information on the majority of our patients. You're going to come across patients that do not give you or want to give you information, or maybe, again, so it's the majority of our patients that we are collecting demographic information on, which with a call out to race and ethnicity and or some of the social determinants of health information. Our hospital has training for staff on culturally sensitive information of demographic and or social determinants of health information. And, I think this one is important because, having an approach and equipping our staff to be able to have some of these maybe culturally sensitive or crucial conversations with our patients, we really need to kind of arm them to be the most appropriate in collecting some of this information. They need to know the why. They need to know what are some of those best practices in having these conversations with patients. And I think it's really going to just make for a more robust data collection effort if we do that upfront training, coaching, and mentoring of our own staff in this data collection. And it's just such an important process and step you should not skip. And then our hospital inputs all of this data collected information and demographics and social determinants of health information into a structured, interoperable, certified EHR technology. So we're not documenting this on paper. We are not, documenting this in maybe like an Excel file or something that you have. This is information that we can abstract from our EHR. And that's going to come into play into domain number 2, which is around data analysis. We want to be able to understand and analyze the demographic information that we are collecting, the social determinants of health information that we are collecting, to be able to then use that data to support our strategy overall, right? And understand where those, where we need to be putting resources to or interventions to. So very important step here. Domain number 3 is around data analysis. So we can attest that our hospital stratifies key performance indicators by demographic and or social determinants of health variables. And to really kind of look at that to identify gaps. And it includes this information on hospital performance dashboards. So, the couple key words here. One is around stratify. So the word stratify really means to kind of to differentiate. So we want to, when you stratify something, you're looking at differences between the data. And that's going to help us understand, maybe there's certain patient groups or subgroups based on various demographics that we can then kind of identify that maybe we need to, maybe it becomes our priority population. And maybe it's defined by race or ethnicity or some type of economic burden. And we're able to then put these kind of key performance indicators on a dashboard that we can then start to monitor performance over time. So this kind of rolls up to your strategy in domain number 1, which included, action steps and a health equity goal. Now you're able to kind of identify based on the data that you've collected and you've analyzed, are we making improvements? Are we seeing changes that are happening in our data that we've kind of stratified by demographic and or social determinants of health, so we can really understand if we are making any progress or what are those trends there. Domain number 4 is titled quality improvement. And our hospital participates, what you're attesting to is that your hospital participates in local, regional, or national quality improvement activities that is focused on reducing health disparities. So maybe some of those quality improvement activities, they may include different collaboratives or partnerships that are focused on decreasing health disparities. You may be participating in a Medicare Quality Improvement Network, or maybe, your MB-QIP network may be focused on reducing health disparities. And that would qualify you for this quality improvement domain here. And so, again, participating in some type of local, regional, or national quality improvement activity. really, to really make sure that you're getting some of those outside resources made available to you, and that you're, partnering outside of just your own organization to improve health equity is really kind of the crux of some of that, the domain number 4. And lastly, the domain number 5 is around leadership engagement. I always say, I feel like, I guess it's not really in order of importance, but domain number 5 in leadership engagement, I would say that that's, very high priority. And it's really great to see on uh, your COT and inventory assessment, where you do have, leadership support for quality and quality improvement. And that's really kind of great to see that that one was at a very high score for you all. But your hospital engages in and can attest to that our hospital senior leadership, including the CEO and hospital board, annually reviews our strategic plan for achieving health equity. And so CMS, just to clarify, defines hospital senior leadership as C-suite and the board of trustees, and not just quality folks, or not just a quality subcommittee of the board. It is, and it also includes, the physician side, so the chief medical officer or any other senior leaders among the hospital medical staff team in this senior leadership category. So really can't think narrow in terms of this one here. Have to have, everyone participate in reviewing your strategic plan, much like your quality assurance performance improvement plan, your QAPI plan. I'm kind of envisioning this as very similar. So again, your strategic plan for advancing health equity must be reviewed at minimum on an annual basis. And at least annually, again, hospital senior leadership reviews any of the key performance indicators that have been stratified by demographic and or social determinants of health. So, back to that domain number 3, if you have that hospital scorecard or dashboard that's been developed with your key performance indicators that tie back to your health equity strategy, your goals and your action steps, that is all and should be kind of monitored and reviewed by hospital senior leadership. And again, I think, when folks review and understand the work that is being done by the hospital and various partnerships that you've all established in advancing some of these health equity measures or key performance indicators, they'll really kind of you'll continue to get that buy-in and that support there. All right. Any questions? I know Laura's marking in the chat. If there's any questions on those 5 key domains, we're going to jump to the social determinants of health or social drivers of health measures. Okay, great. The measures 2 and 3 that are also new in the for MBQIP is around the social determinants of health screening question, or social drivers of health. I think, sorry, again, lots of words that are being thrown out, but for MBQIP's purposes, they're saying SDOH refers to social drivers of health. And so this is a screening for the social drivers of health around food insecurity, housing instability, transportation needs, utility difficulties, and interpersonal safety. This only applies to your adult inpatients. So anyone that's over the age of 18 and admitted to the hospital. And so they must be screened for these health-related social needs, these that were just listed, so 5 of them. And also you need to document the total number of admissions, because we need to get a percentage, right? And again, really preparing you all in this next year to participate in this MBQIP screening question for you. And again, what I've been hearing for a lot of hospitals is that they've implemented a screening tool, right? And they've started to build that into their admission assessment. Has been kind of the majority of folks doing have said that this is what they've kind of built. I've been hearing from a lot of folks that they utilize the Prepare tool, and they've built that into their EHR. And because that is one of the preferred tools for to meet um, this screening measure here. So, and again, it covers those 5 health-related social needs. And they've just kind of built it into their workflow, and they've started to kind of identify patients who are screening positive, which is great because the second part of this measure is the percent of patients that screen positive for one of the listed health-related social needs. So the second part of that is this positive rate measure. And again, those 5 social drivers of health around food insecurity, housing instability, transportation needs, utility difficulties, and interpersonal safety. So of all of the percent of patients that you've screened, what is the percentage of those patients that screen positive for one or more of these 5 health-related social needs? And that will be the second measure of the social drivers of health measure in MBQuip. Does that make sense? Is that maybe we've covered this before? The measure is going to be a chart abstraction measure. You're going to submit that through the hospital quality reporting system. Okay. Also, what I wanted to point out too is, Joint Commission. If you are a Joint Commissioned hospital, you know that there's been some changes in a new national patient safety goal. And you can see that new elements of performance have come out too, specific to Joint Commission around health equity, and very similar to CMS's 5 strategic priorities, as well as the new MBQuip measure on the hospital's commitment to health equity measure. You can see a lot of similarities. We are talking about a strategy. We're talking about screening for health-related social needs, and developing an action plan. How do we identify patient populations by stratifying or differentiating quality and safety data using different social demographic information? What are our action steps to achieving our said goal, to reducing healthcare disparities, and then again informing our key stakeholders in our plans and our progress around reducing healthcare disparities. So folks that are Joint Commissioned, and I know there's a lot of, and I think even Joint Commission has put out for folks that are Joint Commissioned, a certified kind of health equity, seal, if you will. So again, for folks that are really kind of progressed and are far along in that journey, they'll come in and assess you all for a health equity kind of gold standard here. All right. Well, that's it in terms of my high level overview of kind of what we're going to talk about. So the next next steps, and to share more about kind of our upcoming webinars, we're going to break down each one of those key domains. So for the next webinar, we're talking all about strategy. And so really some ideas on how to incorporate and how do we think about developing a health equity strategy, and kind of how do we kind of bring it all together from a strategic perspective. So again, deeper dive into these 5 domains here are going to be for the next webinars. Our next meeting is going to be next month. And so May 13th, same time, noon your time. And we're going, the project activities, we have a few, but again, should not be a heavy lift, but just something to maybe think about and bring back to your organizations. The first one is a health equity gap analysis. I think there's maybe like 8 questions that are within the health equity gap analysis. So if you could complete that for your organization, that would be great. And then the assignment is really to start to think about strategy. So again, building on or building up to the next webinar on strategy. And it's to look at your organization's strategic plan. Maybe it's to look at your community health needs assessment. I think that's also a good place to start too when we're thinking about developing a health equity strategy, is to look at your community health needs assessment. And if review the plan. Maybe you have a team of folks, maybe you have some other individuals that are really kind of embracing health equity at your organization, and think about these key questions. Does your hospital's vision embrace health equity? If yes, what's the vision? If not, is there any tweaks that could be made for your vision to embrace equity? Does your hospital strategic plan outline goals or objectives that relate to health equity? If yes, what are they? And then the last one is, do barriers exist? And advancing kind of health equity as a strategic priority for your organization. If yes, what are they? So if you want to either jot them down in a Word document and you can send those to me in advance of our next webinar, that would be great, or even just drop it in an email. I'll be sending out a separate document that outlines the project activities, as well as a link to the health equity gap analysis. Actually, it's probably going to be coming from Laura, but Laura will package everything and send it off to you all. So if you can do that in advance of our next webinar, that would be excellent. But with that, that is all I have for today. So open opportunity for questions or comments.
We will send out the slides and the recording. Meet with your administration, meet with others in your facility, and send your feedback, comments, ideas, questions, all of that back to us in preparation for that May 13th call. But real quick, before we get off the line, does anyone have any questions or concerns? All right. Thank you so much. And thank you, Lindsay, for your time.
You're welcome. We'll see y'all on the 13th.
All right. Thank you.
Thanks.